We are today facing a very hot topic, something which is really relevant for the good health of our young patients, young girls. And the relevant aspect of this is that we need probably a better understanding on how the issue of obesity might affect and might create conditions so that to trigger physiopathological conditions, aspects, and hypotheses of being sick in the future. So today we will have two valuable speakers, one from France, Professor Charles Sultan, and one from Poland, Professor Blazej Meczekalski, that are both the relevant chief of section one of pediatric endocrinology, Professor Sultan, and the other one, Professor Meczekalski, of gynecological endocrinology in Poland. So the first speaker will be Professor Sultan. He will show us the endocrine and gynecological consequences of obesity in adolescents. And Professor Sultan is the chief of the INSERM research group, chief of the hormone center, and chief of the pediatric endocrinology unit at the University Hospital in Montpellier. He has been really involved in a great amount of projects all over the world, and he has been significantly contributing to the fields of endocrinology and reproductive medicine with a special issue on adolescence development. So, Professor Sultan, the screen is yours. Thank you very much.
Thank you so much, Professor Gynecology. It's my pleasure to share with you some of our experience in this specific field of endocrine and gynecological consequence of obesity in adolescents. This topic is at the intersection of gynecology, endocrinology, pediatrics, and public health. As a matter of fact, this is a new topic since reviews related to this aspect start to be published a few years ago. And actually, there are few reviews related to this topic. Indeed, this is a hot topic that has several impacts in reproductive medicine, in reproductive function of the woman. In the complex, we should consider the patient, the peers, the family, the child's care and school, the community, the society, and the public policy. Last month, a group of international leaders report new consideration for obesity and propose a new qualification of obesity. They redefined obesity for an advancing care for better life. And the new evidence-based definition distinguishes clinical obesity, which is a chronic systemic disease state directly caused by excess adiposity, to preclinical obesity, which corresponds to a condition of excess adiposity without current organ dysfunction, but with increased future health risk. I should say that my talk will be dedicated to mostly preclinical obesity. Next. In the last few decades, as everyone must know, there have been an overwhelming increase in adolescent obesity worldwide. Adolescent obesity causes psychological and social distress in a period of life already sensitive to a girl. As we used to learn, obesity in adolescence has been linked to a myriad of adverse health consequences later in life. But during this lecture, I will focus on a specific aspect of consequence of obesity, of adolescent obesity. I'm talking about endocrinologic, gynecologic, as well as obstetric complication of adolescent obesity in adult life. So, in my opinion, the most important take-home message could be that adolescence is a risk factor for both endocrine and gynecological disorder, pregnancy complication, perinatal complication, and it does also increase the risk of endometrial as well as breast cancer. Let's start with the endocrine and gynecological disorder induced by adolescent obesity. Next, among adolescent female, the neuroendocrine effect of obesity manifests as metabolic syndrome, early or precocious puberty, dysmenorrhea, premenstrual syndrome, heavy menstrual bleeding, irregular menstrual cycle, PCOS, and lastly, risk behavior, and along with insufficient use of contraception. So regarding the endocrine gynecological disorder, let's start by the first one, metabolic syndrome. Also, there is no consensus, just reminding you that metabolic syndrome is characterized by abdominal obesity, disturbed glucose, dyslipidemia, and arterial hypertension. According to several work, metabolic syndrome does occur in 6 to 39% of obese adolescents in the world. The second endocrine gynecology consequence of obesity is early as well as or precocious puberty. We already knew for the last 20 years that greater BMI and adiposity markers were associated with earlier maturation. What we use to share with our fellows is that the fact that obesity, which is characterized by an increased adipocyte number, is associated with increased aromatase activity that convert androgen to estrogen. And this peripheral estrogen production could induce precocious puberty. I should say peripheral precocious puberty. As a matter of fact, we know for the last few years that adolescent obesity does induce a central precocious puberty. Through high-fat diet induce hypothalamic inflammation with a microglia activation and a subsequent GnRH activation, and so on, and so early or precocious puberty. So this is a very important concept, is the fact that obesity has some impact in structural neuronal change, and specifically reduced gray matter volume. So obesity in brain does modify the neurochemical profile by decreasing no aspartate, while increased glutamate, that is activator of GnRH neuron. On the other side, obesity is associated with cellular change in the hypothalamic neuron through the microglia activation. And as you can see on this beautiful slide, the high-fi diet impact microglia and prostaglandin activation, increase phenixin level, gut microbial and hormone release, as well as overexpression of p53 through the lin-28, which is an activator of GnRH. And all these factors together are responsible for GnRH activation and precocious pubertal development. The third consequence of obesity in adolescents are related to menstrual disorder. Next. The first one, dysmenorrhea. We know, although there are some discordant data, but in my experience, having managed thousands of adolescents with dysmenorrhea, I can assume that dysmenorrhea is much higher in obese adolescents, even if for some experts there is a U-shaped association between dysmenorrhea and BMI. The second menstrual disorder is related to premenstrual syndrome. We know that high BMI has been associated with increased risk of PMS. As a matter of fact, BMI above 30 is linked to 3 times more prevalence of PMS. So yes, adolescent obesity is a risk for PMS. The third gynecological disorder are represented by heavy menstrual bleeding. In the next slide, there is a beautiful work. I'm talking about an experimental work that clearly explained the pathophysiology of heavy menstrual bleeding in obese people. In experimental data, this group recently, 2 years ago, demonstrate that heavy menstrual bleeding could be related to endometrial hyperplasia. That is a key factor. We know that heavy menstrual bleeding. And this endometrial hyperplasia is related to an increased aromatization of androgen to estrogen in adipose tissue, resulting in hyperestrogenic state that stimulate endometrial growth. And besides, the production of adipokine by adipose tissue contribute to a pro-inflammatory state. The next menstrual disorder is the irregular menstrual cycle. It is well known by most specialists in adolescent gynecology that girls with higher BMI and a higher percentage of body fat were more likely to experience irregular menstrual cycle. Next one. The last but not the least, endocrine and gynecological disorder of obesity is PCOS. This is not a new topic. It has been proposed some years ago that childhood adiposity could contribute to the development of adolescent PCOS in specific conditions. Retrospectively, it has been published by several groups that obesity, in adolescent obesity, the diagnosis of PCO range from 10 to 25%. So obviously, I don't have too much time since this topic will be discussed by the following speaker. There is a link of obesity. How? The first one is adipose tissue. Increased adipose tissue during obesity is responsible for insulin resistance and environmental endocrine disruptor chemical. And obesity has some direct impact on insulin resistance, as I previously mentioned, on the overproduction of adipokine, and on the activation, hyperactivation of the GnRH pulse generator. So, as you can see, PCOS is the best illustration of the link between obesity and a disorder of menstrual cycle. The second complication are related to pregnancy complication. Next. Pregnancy complications are present with a high prevalence in those women who had a previous adolescent obesity. So this increased the risk for this young adult to develop a gestational hypertension, preeclampsia, gestational diabetes, primary cesarean delivery, as well as induction of labor. The last complication of adolescent obesity are represented by the perinatal complication. Next, infants born to obese teenagers are more likely to have perinatal complications, such as preterm or post-term delivery, small for gestational age, newborn, macrosomia, meconium aspiration, respiratory distress, as well as stillbirth. So this is an association of disorders that are not actually very well known by endocrinologists, even by OBGYN. Last but not the least, adolescent obesity should be considered as a risk factor for endometrial cancer and of breast cancer. Even if it's not a direct relationship, it is one of the risk factors through the hyperinsulinism, hyperproduction of IGF-1, and this impact of these two factors of the cell growth, multiplication, and differentiation. There are several reports in the world that clearly suggest that adolescent obesity increase the midlife cancer risk for all cancer, but specifically for breast and endometrial cancer. This is a work published in Lancet from a patient from Israel. And this is another work recently published from Eastern country, which showed the association of adolescent obesity with the mortality of all kinds of adult cancer. So definitely, this is a risk factor that should be kept in mind when managing adolescents with obesity. The second take-home message, which is, in my opinion, one of the most important, childhood as well as adolescent obesity may compromise reproductive life in adult women, and we know that this adolescent obesity could lead to infertility in adulthood. The second conclusion, as you can see, is in this beautiful picture recently published some months ago. So female fertility, what the link between obesity and female fertility, there are at least 7 ways through which obesity is a risk factor for female infertility. The first is the disruption of hypothalamo-pituitary-ovarian axis, a disruption of GnRH, a high secretion of FSH and LH, and anovulatory cycle and irregular menstrual period. The second one is the responsibility of the adipose tissue itself, which is a true factory which product 25 different chemical substances. Unfortunately, I don't have time, but it's a beautiful part of the development of obesity. And this increased adipose tissue is associated with a change in adipokin and ovarian steroidogenase and endometrial setting. The third aspect is insulin resistance and hyperinsulinemia and the overproduction of androgen, as I previously mentioned. The inflammation, unload, and oxidative stress are responsible for an hostile environment for oocyte and for endometrial lining receptivity. Repercussion of dysregulation of lipid metabolism induce a cellular stress for granulosa cell. Mitochondrial dysfunction is responsible for an alteration of oocyte growth, and dysregulation of biogenic amine modify the secretion of serotonin, dopamine, and induce inflammatory state and oxidative stress. As you can see, the link between obesity and female fertility is far from being directly associated with the hyperaromatization of androgen by adipose tissue, since it does include several factors, several actors that contribute to female fertility. Next and last. So I've tried to demonstrate with this talk that maintaining a healthy weight in adolescent girl can reduce the risk of endocrine and gynecological complications of obesity in adulthood, since all over the world there is a dramatic increase in prevalence of adolescent obesity, we should be very strict with our adolescent girl when we manage them either for adolescent obesity or for another disease. Never forget that obesity is not a sign, it's a complete syndrome that interfere with the future of this adolescent girl. And from my last slide, I would like to thank you for your attention. From the School of Medicine of Montpellier, which is the oldest school of medicine in the world, and of which I was very proud to be one of the last vice dean of this prestigious house. Mr. President, ladies and gentlemen, thank you for your attention.
Thank you very much, Charles. And as it is usual, you gave a wonderful lecture of culture and of clinical skills. Thank you. Thank you very much. You are always on the edge. I have to say, you are still too much young in the brain to show us that you are able to give us the real perfect information how to face the transposition and the evolution of the child, of the young women, through the adolescent stage up to the fertile life. So
thank you. But please don't talk about my brain, please.
No. You are clever enough to know that I am absolutely true and correct. So it's my pleasure now to go on with the webinar. Now it's the turn of Professor Blazej Meczekalski. He's a very dear friend. He's professor in obstetrics and gynecology and in endocrinology at the School of Poznan University in Medicine. And he has been working with me and with several groups all over Italy, and mainly facing all the aspects of the gynecological endocrinology issues from the beginning of the young girls up to the menopausal transition. But today he has to face the topic of PCOS in adolescence, something that we have just now understood that is triggered by a lot of factors, but obviously being as gynecologists, we face the aspect of such kind of complication induced by obesity only when the young girls are around menarche or just after menarche. So, Professor Meczekalski, ongoing riddles in diagnosis and treatment of PCOS in adolescence. We depend from you now. Thank you.
Thank you. Thank you very much, Professor Genazzani, for this kind introduction, and thank you for inviting me to this webinar. I have no conflict of interest to declare. The basic question is, what is polycystic ovary syndrome? If you look at this picture, considering pathophysiology, we cannot say exactly what is PCOS. Why? Because you can look how many factors, according to our current knowledge, can be involved in the pathophysiology of PCOS. You can see that different metabolic factors, like also Professor Sultan described, the interplay between insulin resistance, androgens, other factors related to metabolism, also the impact of environment. For instance, the endocrine disruptors can be considered, also disorders in the sense of the steroidogenesis disorders, like, for instance, increase of 17-alpha hydroxylase. Finally, some disorders at the level of the ovary also can be taken into the consideration. And I cannot omit the genetic background with different mutations of different genes, epigenetic aspects, methylation, microRNA. And finally, which is now a very hot topic, the neuroendocrine background of PCOS. We know that PCOS can be associated with the increased pulsatility of GnRH due to higher expression of kisspeptin, which can control GnRH pulsatility. In turn, it can cause the increase of the LH pulsatility frequency and also increase of the basal LA, and in turn, the stimulation of theca cells and high levels of testosterone, which in turn can cause disturbances in the feedback system of androgen, progestin, and estradiol on the hypothalamic levels. For instance, a few years ago, we studied with Professor Alessandro Genazzani that although it was not studied in the adolescence patient, but in the patient in the productive age, PCOS patient, we found some disarrangement in the kisspeptin and LH co-secretion between PCOS patient with oligomenorrhea and PCOS patient with eumenorrhea. The natural history of PCOS is very long. I cannot concentrate on a lot of publication, but please look, you can read by yourself that even more than 2000 years ago, Hippocrates in the book Disease of Women described probably women with the symptoms typical for PCOS. We know very well publication by Stein and Leventhal from 1935, but please look that more or less 90 years before this publication, Arshil Charot perfectly described histopathological appearance of the polycystic ovaries. Why this topic is such interesting? It depends from different points, of course. We still don't know, as I mentioned, the pathophysiology of PCOS. Still, the number of the publications concerning PCOS in adolescents is relatively or significantly smaller than concerning PCOS in reproductive age women. Whereas, due to the young age and different physiological mechanisms related to puberty, also there are some controversies how to diagnose and how to treat this syndrome. Why? For instance, we know that one of the most typical symptoms are irregular menstrual cycles for PCOS and irregular ovulation or anovulation. But we know that during the pubertal time is something normal, that at the beginning, after the first menstruation, is physiological due to maturation of hypothalamic pituitarian ovary axis, that these cycles can be irregular. Still is the kind of the delay in the researching on this field in adolescence in the comparison to PCOS in the adults or reproductive age women. Even the first criteria was developed to diagnose PCOS in adolescents relatively few years later after the Rotterdam criteria. Here you have the criteria developed or published by Lourdes Ibanez Group in 2017. You can see what are the required points: irregular menses, oligomenorrhea, evidence of hyperandrogenism, biochemical or clinical. Not recommended here is points related to metabolism. Of course, according to these criteria, we need to rule out other causes of hyperandrogenemia. And in 2020, very nice paper was published by Pena Group. It was later, almost the same criteria was presented in the recommendation from 2023 International Evidence-Based Guideline for Assessment and Management of PCOS. The first author, Helena Tede from Australia. And these criteria are, in my opinion, very precise. You can see hyperandrogenism, evidence of clinical hyperandrogenism, moderate to severe hirsutis and or severe acne, evidence of biochemical hyperandrogenism, different kind of menstrual disorders, irregular menstrual cycles, depending how many years they occur, how many years post-menarche, and it's stressed that we cannot consider polycystic ovarian morphology as the criterion, and pelvic ultrasounds should not be performed in adolescents less than 8 years post-menarche. What's about metabolic aspect? Generally, they are not accepted as the criteria, but we cannot completely ignore them. Why? Because they can work for us as the warning sign to look for the further risk and later reassess the problem. Here is the same criteria, but in the graphical representation. But apart from patient with the diagnosis of PCOS, adolescent diagnosis, we need also to remember about the patient who are at risk of PCOS. For instance, you have here clearly presented, for instance, isolated menstrual irregularities, but no hyperandrogenism, or hyperandrogenism and regular menstrual cycle. And what is important, this patient and the risk of PCOS, we should follow up them. We should recommend the healthy lifestyle. And as I mentioned previously, in the sense of the patient who are at risk, we need to reassess them in the proper time. Still, I probably mentioned that as in the adult patient with PCOS, we know more or less what is the prevalence, according to the literature, between 10 to 15% in the women of reproductive age. But still is not very clear information about prevalence of PCOS in adolescents patient. Here you can see the nice publication from 2024 from European Journal of Endocrinology, and they try to assess the prevalence of PCOS in adolescents according to the different criteria. According to the International Evidence PCOS Guideline or Rotterdam criteria, and respectively 6.3 and almost 10% according to Rotterdam criteria. Which parameters should we evaluate? Of course, the important is to evaluate the androgens, like testosterone, androstenedione, dihydroepiandrosterone sulfate, FSH, LH, thyroid function, of course, fasting glucose, or lipid profile, or oral glucose tolerance test. I just previously mentioned about other symptoms, not only irregular menstrual cycle, but hyperandrogenism. It is referred to moderate or severe hirsutis and severe acne. We know that one of the symptoms is alopecia in adult patient, but due to the lack of the studies which can clearly evaluate this problem in the sense of diagnostic criteria in adolescent patient, we cannot evaluate alopecia, or you can use as the diagnostic criteria. What's about the other problems, other possible markers, new markers like AMH, like according to new criteria in adults, we can evaluate it, but in adolescents, according to this recommendation, no. Also, no others like microRNA. Another important problem, which is more difficult in adolescents than in adults patient, is the polycystic ovary morphology. We know from my previous slide that this is not the criterion. The problem is that due to the maturation of the hypothalamic pituitary ovarian axis, the quite high number of adolescent patients, you can see here the percentage, during this adolescent time can present the pictures of the ovary, which is typical for PCOS. And I just mentioned that it's not useful to perform the ultrasounds to evaluate morphology of the ovary in these young women, because we can evaluate it only 8 years after first menarche. Another important problem which is arising now is not only problem related to irregular menstrual cycle or anovulation or oligoovulation, not the problem with the metabolism, but the problem related to mental background or mental problems. In other words, such problem like depression, anxiety. A lot of study found that not only in the adult patient, but even more in the young patient, this problem in PCOS, adolescents PCOS, is very important. You can see, we can divide the pathophysiology of this problem into the populational risk, biological predisposition, psychological factors, family issue, and PCOS-dependent factors, like hormonal abnormalities typical for PCOS. We know about hyperandrogenemia, symptoms of the disease, for instance, acne, hirsutis. Also, Professor Sultan mentioned previously about fertility issues in this patient, not only patient with obesity, but also patient with the PCOS. And of course, the disturbances in the body perception associated with the PCOS. What should we do according to this new recommendation through 2023? Anxiety and depressive symptoms should be routinely screened in this adolescent patient. They suggest the use of the back depression an inventory and also the patient health questionnaire for adolescents. Of course, we cannot omit the metabolic problems. We know how they are important. It depends on different country. The prevalence or incidence of obesity in PCOS young patient is very high, between 50 to 80%. The same insulin resistance percentage in this young patient is very high. It has correlation with the really increased risk of diabetes mellitus type 2 in these young patients with PCOS. How can we approach, how can we help these young women? In the sense of metabolic problems, the weight loss and increased physical activity is the first point, the first line of the therapy in overweight or obese adolescents with PCOS. What can we advise to these women? Of course, the change of lifestyle in the sense of the combination of a calorie restricted diet and also very important is the physical activity. Increase of physical activity is recommendation at least 60 minutes of moderate to vigorous intensity and at least 3 times weekly the strengthening of the muscles. Of course, this 60 minutes intensive physical activity should be every day. What about pharmacological treatment of PCOS? We know that for the treatment of irregular menstrual cycle and hyperandrogenism, the first line of the treatment is combined oral contraceptions. According to this guideline from 2023, our prescription should be based on the general population guidelines, WHO, considering contraception, and a specific doses of progestin, estrogens, or combination cannot be currently recommended. Of course, when we use oral contraception, particularly in these young women, we should be very aware about the contraindication, absolute contraindication and relative contraindication. And also, we should consider such risk factors in these women like obesity, hyperlipidemia, and hypertension. Another important aspect are metabolic problems. I just mentioned that the first line of the treatment is the change of the lifestyle, diet and physical activity. But another important drug can be helpful here, insulin sensitizer, metformin, which can be evaluated in the clinical trials for a long time. And we can use them in addition to the lifestyle in this patient or in combination with combined oral contraception in adolescents with PCOS, for instance, when they are overweight or obese, if also the lifestyle is not enough to improve the problems. The second line treatment, if the use of the oral contraception is not helpful and does not improve or the described problems, or patient is open to change to improve the therapy, we can consider anti-androgenic medications. you can have listed here, like flutamide is not available in some countries. We need to remember about its hepatotoxicity. Spironolactone can be a good choice. You have here the initial dose and maximal dose. Cyproterone acetates, but you know that with this drug we should be very careful. Also, according to last publication, considering the increased risk of the meningioma, and also finasteride. And apart from this typical pharmacological treatment, we can also consider, of course, in these young women, cosmetic therapy, like cosmetic hair removal referred to bleaching, chemical epilation, plucking, waxing, shaving, electrolysis. Photoepilation is recommended as the first-line management of localized hirsutis in PCOS. But apart from this classical treatment, which I described, there are also considerations now about some possible new option of the use, particularly or hopefully in these young women. Like, for instance, an acetylcysteine. In some study, you can see that it can be helpful to decrease the BMI, improve the insulin sensitivity, decrease the testosterone. Inositol also, according to some studies, can be helpful in these metabolic aspects. Vitamin D and chromium supplementation. And of course, maybe in the future, 1 week ago, I had the pleasure to present the topic in the during the webinar on neuroendocrine aspects of PCOS. The neurokinin B antagonist may be in the future helpful. So far, only 3 clinical trials, no in adolescents, but in adults, were published in the PCOS patient, and it was noticed that it can improve the LH pulsatility, decrease LH, and decrease testosterone. And carnitines. Carnitines also can be kind of the choice in these young women. Why? Because they can have a positive influence on the increase of the insulin sensitivity, menstrual cycle regulation, and decrease the hepatic insulin extraction. What's a carnitine? It's molecules which were discovered more than 100 years ago. You have here the biochemical structure, and they can be synthesized in the body from this amino acid listed here, or taken from the diet, mainly from the meat. Therefore, the name is carnitine. And the carnitine, they can have very broad action, both systematic, listed here. They increase, first point, increase beta oxidation of long-chain long fatty fat acids, and also reproductive function, refer to antioxidant effects, anti-apoptotic effects, and anti-inflammatory effects. And here is the example of our study, although it's not in the adolescent women. This study, the first author is our kind of the example of the collaboration with Professor Alessandro Genazzani. We try to evaluate this integrative treatment with the use of listed molecules like L-carnitine, acetyl L-carnitine, L-arginine in the patient with PCOS. The treatment lasted 12 or 24 weeks. And what was the main result? I will not tell in the details, but the main points we observed the significant reduction of plasma insulin levels and also decrease in the triglyceride, total cholesterol, and HOMA index. Here you have graphical representation of these results. You can have in the baseline time and also after 12 weeks and 24 weeks. And another very new study published just in this year, 1 month ago, Gynecological Endocrinology, also integrative treatment, the same, more or less similar content, but also inside was myoinositol. And the results were also promising because was significantly improved metabolic parameters, homeostatic model for insulin resistant index and gonadotropin plasma levels. And at the end, what's some news in PCOS during the last 2 years? You can see that this is very good review, actually from Poland, Jakubowska-Kowal, published 1 year ago. They suggest that is important to identify, as I mentioned, the risk group which can be threatened by some psychiatric problems like depression or anxiety. They suggest maybe the periodic examination of blood pressure, biomarkers, or lipid metabolism. Also, they suggest we know about the problem of non-alcoholic fatty liver disease. Also, can be the problem in these young women with PCOS. Here, other publication, for instance, the helpful role in 12-week aerobic exercise and important positive influence on these parameters. Also, there are some publications about positive influence of alpha lipoic acid on the both menstrual cycle and decrease of BMI. And please look from this publication, what are the main problems in these young women with adolescents PCO. Here, 60% presented obesity, but please look, also very important problem in these young women, eating disorders, almost 50%, staying stressed, 40%, and other like thyroid dysfunction, 20%. And at the end, I would like to present a little bit different view on the pathophysiology of PCOS. Presented, it is also quite new publication by Lourdes, Libanez, and Dezeger from 2023. They suggest that we should not use the polycystic ovary syndrome or in adolescents or adolescents PCOS. Why? They proposed the term postpubertal central obesity syndrome, because according to their conception or hypothesis, the central obesity is the main problem. They refer even this problem to late prenatal and early postnatal life, in the sense of the increase of the weight, which can have important influence on adipogenesis and lipogenesis. And later, it can have influence this problem, ectopic fat, insulin resistance, higher blood pressure in the early childhood, and also consequences for late childhood, puberty, and adolescent and early adulthood, in the sense of the disturbances of these hormones like dihydroepiandrosterone sulfate, LH pulsatility, thyroid free testosterone levels, and thyroid disorders. But after the publication of this paper was the letter to these authors wrote by Helena Tede and others authors listed here, and they suggest that they don't agree with this conception. They propose that this name would not apply to 50% of the patients who are not obese in Caucasian population and the majority of those in other population like East Asia. It would not apply to those who are not adolescents and would theoretically require a change to a new name in women once they reach adulthood. Or our extensive international surveys of patients showed that very few want to be labeled with a syndrome that has obesity in the name and does not adequate consider stigma and patient implication of such name. Thank you very much for your attention. It was a pleasure to present this topic.
Thank you very much, Professor Meczekalski, and it's typical of you to give a wonderful lecture, and you have been really extensive on this topic. So let's start to have a little bit of discussion on the presentation. I might introduce some specific ideas on these. I would like to gather at least the observation that Professor Sultan suggested and gave us that are the relevance on how these young kids might evolve towards adolescence. And it's rather important to fuse these with what Professor Meczekalski have just now finished to show us, that are the evolution during adolescence of these young girls. So there are a lot of questions that are coming in the chat. So I would try to put all of them together. I have another question quite interesting, which is for Professor Meczekalski. When we have obesity in some adolescents and we have weight loss, what are the consequences if the loss of weight is too much? Or have we to lose a lot of the body weight?
Thank you for this good question, because sometimes patients are very happy that they want to weight loss and they lost a lot of kilograms, but sometimes is not very good, because in this situation, sometimes due to the energy imbalance, they can have other problems like PCOS, because even in the PCOS patient, when is the severe weight loss, it can be converted to functional hypothalamic amenorrhea. And too much weight loss can have such impact that we need to treat the patient due to functional hypothalamic amenorrhea.
Oh, yeah, that's relevant, Biagio. It's relevant, but I think that we might add something else probably, because childhood and with obesity and obesity during fertile life are quite tightly linked with one with the other. So the question from one of these colleagues from the audience is, what are the specific genetic conditions that might drive from adolescence to fertile life insulin resistance? Everyone will be insulin resistant independently from other conditions, just being obese?
No, in my opinion, no, because as it was written in this question, exactly, it is the complicated problem, because it cannot result only from the, how to say, BMI or number of the kilograms of the fat tissue, but also can have the genetic background in the sense of different person. And the risk of insulin resistance can be different in these persons.
Oh, that's interesting. But I have another question, which is I'm quite interested in the response that you might give to us. there is any linkage between diabetes, familial diabetes, and the chance to be obese and or to develop obesity during fertile life. So it's a different way of looking at insulin impairment in these patients.
This is question for me or Professor Sultan?
For you, Biagio. We are missing Professor Sultan. So we are using you as the driver of the discussion.
Okay. Could you repeat the question because I am a little bit confused with the reading?
No. The question is just if familial diabetes is something which we should try to find and to take in consideration when trying to solve and treat the obesity in these young patients.
Yeah. Yes, of course, because if it's the familiar diabetes, this patient can have the increased risk of obesity, and also according to the different studies, can be the increased risk of the PCOS also in these patients.
Okay, and the consideration that the recent guidelines on PCOS have given us that probably the AMH assay and the criteria for ultrasound are more or less similar, or you should probably take in consideration one or the other. On your opinion, on your experience, should be best for the young obese girls. I don't want to say adolescents, but maybe just post-pubertal, so quite young in any case. Do you think that AMH is better than having an ultrasound of the ovary?
According to this criteria or recommendation from 2023, AMH, anti-Müllerian hormone, is only recommended in the adults, is not recommended in the adolescents. Probably, in my opinion, it's due to this that still there is the maturation of the ovary, the development of the follicles, and we cannot consider AMH as the stable criterion. But on the other hand, it also is, very interesting that even if we consider AMH in adults patient in PCOS, but in this recommendation, there is not cut off. There is not the exact value from which we can consider it. Yeah?
Okay. And Biagio, what is your feeling on the use of metformin? On your experience, is metformin good at any age, or we might a little bit take care of the age of the young subjects? I want to say we can use these just in girls around 10, 12, if they are obese and insulin resistant, or we have a little bit to wait some time after the beginning of the pubertal development.
Personally, from my experience, I have more experience, let's say, to use metformin in the patient at the age 15 and above. And in my opinion, it can be used in this group of patients, but even more experience with the metformin I have with the patient adult. I have never used metformin in very young patient, as you told, 10 or 11 years old.
Okay, I have a little experience on this, and I have to say that the very low dose, the so-called half a pill of metformin, 250 milligrams after or just before lunchtime, avoiding carbohydrates during the dinner, might be used with good results. But I have
also, Alessandro, when you told,
yeah?
I think that according to our study, although they were not in the adolescence patient, the use, for instance, of carnitine also can be the good choice in these adolescent women, because they are, how to say, composed of different components, not only carnitine, but others which I described. And in my opinion, they can have good impact to improve metabolic problems and also menstrual disorders in these young women.
Absolutely, I agree. And I would like to little bit stress this topic, since the data from our study Biagio, but also from our group in Modena, have clearly demonstrated that the impairment that we have during obesity, which is the pro-inflammation, the excess of oxidation, are able to impair great part of the activity of specific ability of the liver. And this means that the hepatocyte is not able to clear completely insulin from the blood. So this creates a sort of maintenance of a higher level of insulin because it is not taken away by the degradation of the liver. And we have demonstrated, and in part of the study, you are a co-author with us, and you have clearly defined the topic talking about carnitines, that the antioxidative effects of such nutrients obviously are able to improve the antioxidative agents inside the biology. So this means that if you have something blocking the production of reactive oxygen substances, you might improve insulin sensitivity. And this is a classical activity that can be induced by carnitines, N-acetylcysteine, L-arginine, alpha-lipoic acid, and recently
inositol also.
Inositols, and greatly also with corosolic acid, which is extract from the banaba leaves, is a plant. And all such substances are able to induce a specific, quite relevant antioxidative activity, which improves the reactivation of the most important endogenous antioxidant substance, which is glutathione. So it's clear that probably it's important on one side, the diet. So I agree with you when you gave the indication on how to face the problem of the obesity and PCOS in these adolescents, that the lifestyle is relevant. You have to take care on what kind of food and on the quality of the food. But you might use, and you you have mentioned them clearly, you can support such kind of activity with a good lifestyle, with a specific integrative substances. So just to give a little bit of a summary on this, what is, on your opinion, in the classic overweight obese PCOS, young PCOS, with hyperandrogenic signs, what are the steps that you might suggest for diagnostic approach and then for the choice of treatment?
Young with the hyperandrogenism and metabolic problems, yeah?
Yes.
As I mentioned, probably the first point will be the improvement of the lifestyle. As I mentioned, diet and physical activity. It will be the first point, yeah?
Yes.
Later, we probably to improve the hyperandrogenism, we can add combined oral contraceptive. If it works together, that, for instance, metabolic problems will improve after this change of the lifestyle, and combined oral contraceptive will work, it's okay. This kind of the treatment works. But if this kind of the treatment will not work in the sense of the improvement of metabolic problems, we can add, for instance, metformin.
Absolutely correct. I agree with this such kind of view. And we have a specific question, which is a little bit more for Professor Sultan, but we do not have now the connection with him. But let's discuss you and me. We have a
Yeah.
question, how to manage hirsutism in a girl of 9, 10 years old. The mother is very concerned about the hyperandrogenism. What might be the right drug or what we might suspect and do?
Mhm. Yes, I can see this question. This is really very young girl. In my opinion, it's how to say, not easy now to tell about the treatment, but we need to make we need to try to make the precise diagnosis. What is the region of this, the reason of this hirsutis? We need to evaluate the hormonal profile, and we need to evaluate androgens, because it can be different causes. For instance, sometimes can be also the ovarian tumor, which can produce the testosterone, and it can be the cause of the hirsutis. In my opinion, first we need to know the diagnosis to treat it.
Yes, and I might add another observation that we have the so-called exaggerated adrenarche in some
Yeah,
of these
exactly.
young girls.
Mhm.
And this is not always, but quite often linked to a condition of familiar diabetes and on being born small for gestational age, or maybe preterm, or maybe as UGR.
Uh-huh.
And this means that you have an hyperactivation of the insulin resistance, which induced hyperandrogenism. So I agree, you have to study quite attentively this kind of patients. And another question, quite easy but relevant today, can we use GLP-1 agonist in these patients?
Yeah, now is very, how to say, fashion about this kind of the drug, let's say in adult patient. As I know, in the literature, there are suggestions or some study undergoing about the possible use of this drug in the adult patient, but I'm not sure if they are recommended in the adolescent patient. Probably, according to recent study, they are not recommended in the adolescent patient with PCOS.
Yes, I think that the first part of the answer is perfectly targeted. I mean, it's very fashion. It's much easier to have the pill of the puncture that makes
Yeah.
you lose weight than paying attention to
Yeah. To
reduce.
close eating, to finish eating,
Exactly,
to stop
exactly.
eating.
So stop eating. Well, the data that I do not have personal data on this right now, but the friends which are dealing with diabetes and severe obesity told me that they can get good results in loss of weight, but as soon as GLP-1 agonists are reduced in the dosages or stop the administration, if you do not gain the ability to control the food, you recover the body weight quite quickly in very few months. So
Yeah.
it's really important, the aspect that you have mentioned, the psychological aspect or the psychological support for these patients who are quite obese is very relevant,
Yeah.
because you have to learn how to face not only the relationship with food, but also the everyday life.
Yeah.
What do you think on this?
Yeah, I agree completely, because the first point, in my opinion, apart from the drug about which you mentioned, is to control food eating and to use physical activity, because as quite often after suspicion of the use of this drug, we can the yo-yo, how to say, symptom, né? is the return of the weight again. Yeah.
Yes. And I have a question which is quite interesting. Looking at the fact that the most debilitating health concerns with regard to PCOS is obesity, is it reasonable to have the evaluation of insulin resistance and or insulin levels in adolescents?
Yes, I think that that it can be evaluated in adolescents, not only glucose level, insulin levels, and HOMA index. I think that it can be worthy.
Yes, I agree. The idea is that I think that when we, how to say, face the aspect of the PCOS in young girls and we have to find a solution, obviously, we probably have to be a little bit less gynecologist and more general practitioner. The meaning of this is that we have to ask to the mother or to the young lady, are you born at the right moment or preterm?
Yeah.
How was the body weight when you born? You were below the normal weight or above the 4 kilos macrosomia? And what about the family? So we have always to ask if there is anyone with diabetes in the family, because the familiar predisposition creates a link to get an insulin excessive response to carbohydrates when introduced. So I think that we have a little bit to be attentively looking to such kind of details.
Yeah. For instance, today in my department, we have the patient, it was not adolescent patient, but 19 years old with the, how to say, diagnosis of PCOS. But the main point when I took the medical history with her was that, of course, she was obese, but the lifestyle generally, she didn't use any physical activity. She has the very stressful life mainly in the sense not family life, but stress in the work. And when I look in the results, the hormonal levels were not generally in the normal range. The testosterone was in the upper normal range, but completely changes were in the metabolic profile. Was the level of the glucose was 120 milligram per deciliter, and also was the lipid profile totally disturbed. And this patient doesn't take care about diet, and also when I talk with her, she's smoking.
Oh. The smoke is the cigarettes.
The perfect example of the metabolic problems, and kind of the perfect example if she will be persistent and how can she solve this problem with the help of the doctor.
Yeah. I have a final question for you. We are missing, unfortunately, Professor Sultan, and I have been told by the backstage that there is a problem with the connection with France, unfortunately. Anyway, is there any difference between PCOS non-obese and obese PCOS? So should we have to consider these with non-obese as a specific different entity from the other one?
This is, difficult question.
Yeah.
Kind of the philosophical question. Even if I would like to go more broad, still is the question, what is PCOS? Because according to the criteria, mainly, let's say, also in adults, we can say that is more reproductive disorders. Because in the criteria, you cannot find any metabolic parameters, yeah? But still is the question, in which extent this is reproductive problem, but in which extent metabolic problem. We know not only in adults, but also in adolescents, that this patient, as I described today, patient from our department, they have a lot of metabolic problems.
Yes.
And is the question, should we maybe in the near future to add some parameters to the criteria, even for these lean women? Because it's also the truth that is not going such way that only overweight patient or obese patient with PCOS have metabolic problems. Sometimes, and it was written in the question, that sometimes lean patient with the normal BMI also can have metabolic problems, like, for instance, insulin resistance and disturbances in the lipid profile.
That's great. In fact, I would add something, which is that the American Society for Reproductive Medicine, after that, the first Rotterdam criteria have been proposed and applied in our clinical practice, have added just an observation that to be sure to be able to get if any kind of metabolic impairment was present, it was suggested to perform an oral glucose tolerance test to all patients with the Rotterdam criteria PCOS.
Oh.
Because, and I have done such kind of, let's say, observation in patients in our area in Italy. And we have disclosed a very silly but relevant aspect in these patients, that the two kinds of patients with PCOS, Rotterdam criteria, the one with obesity, the one which is normal weight, at least 70% of the so-called normal weight PCOS are patients taking strictly care of the nutrition, of the physical activity, of not having too much carbohydrates, no pizza, maybe sometimes, but not always.
Yeah.
So what is the aspect that we disclosed saying so? That probably the insight of PCOS is really to have a metabolic impairment. But if the patient is performing running or the gym and taking care of food, the balance in input and output of energy is taken under control, and hyperinsulinemia, at least without doing the oral glucose tolerance test, is not discovered.
Yeah.
So I agree with this very old suggestion of the American Society for Reproductive Medicine, and we perform the oral glucose tolerance test at least 4 points in all our patients who have the criteria, positive criteria of the Rotterdam. And I have to say that we have disclosed that at least 35% of the so-called normal weight PCOS have an exaggerated response of insulin under the oral glucose tolerance test, with a very normal or just below the levels of normality insulin at the fasting blood collection in the morning. So this means that the PCOS and these metabolic aspects have a dynamic aspects, and we have probably to take care also of this.
Yeah. Although we are gynecologists, as you told, we need to have the internal or metabolic knowledge.
Absolutely, I agree perfectly. And remember that we are members of the International Gynecological Endocrinological Society, which is the perfect connection of the endocrine aspects and the endocrine knowledge applied to the gynecology and obstetrics of women. So we need absolutely to remember that whatever is happening in our biology probably have to be connected and to deal with endocrines, control, and hormonal molecules. So I think that we have reached the length enough for the webinar. I have been assigned that I have to stop now. So I would like to say thanks a lot to Professor Meczekalski. I'm very sorry that we have missed Professor Sultan, but I apologize for him with all our audience, but I will be sure that in the next chance that we will have with Professor Sultan, we might have incredible discussion with him. And I thank you very much for having been with us. And I suggest please follow, obviously, all our programs, all our presentation. Next time we will have wonderful speakers, and we have, you see here the slide, Professor Glutamoc Celis Gonzalez from Mexico, Professor Sara Berga from USA, and Terni Piltonen, which are the top of the aspects in terms of dealing with PCOS. And we will discover new aspects and new issues on this. Thank you very much. Thank you very much, Biagio. See you in Riga. We have the next meeting very soon. And obviously, we have more or less 1 year beyond the next ISGE International Congress, which will be not in Florence, but in Rome, in the cloud, in the beautiful Roma. And thank you very much, and see you soon.
Thank you.